evening, everyone, and welcome to today's wonderful evening with Dr. Dhairya,
Hi guys.
Our medicine teacher and the recent NEET PG topper. Always those who cracked the recent NEET PG entrance will be jubilant, energetic, with a lot of knowledge, and the required trick to pass the NEET PG exam lies with the recent toppers. So that is the reason every week we will have a session of NEET PG fight with one of the NEET PG toppers, so that it is like a jugal bandi, like two ustad having a kind of a discussion kind of a learning. So thank you so much, Dr. Dhairya. In spite of being post-duty after a challenging general medicine residency duty is like the most challenging thing. So let's make a great beginning. So yeah,
Thanks for having me. Thank you for having me here.
Great. Wonderful. So today we have a set of cases, and we will be discussing either the management or the diagnosis or the treatment of each of these cases, and that is how we will try to finish a lot of common clinical vignettes which are going to come in the tomorrow's NEET PG exam. So let us make the beginning. A 8-year-old boy presents with a painful swelling of the hands and feet, jaundice and anemia. He's also having splenomegaly. His blood film is showing target cells. So how do you like to comment on the diagnosis and cause of anemia in this case, doctor?
So now this patient, first thing to note is that this is a male child, right? So when you think about it, what is more common in male children, and you would first think of cases such as sickle cell anemia, such as any X-linked condition, hemophilias and Alport syndrome. So these things more common in males, and this patient has come with anemia and jaundice. So that makes us think of some cause of hemolysis, and when you look at target cells, that gives us the diagnosis of sickle cell anemia. This patient is having a sickle cell crisis. So what are the crises in sickle cell anemia? What are the crises in sickle cell anemia, right? The first would be a sickling crisis. That would be yeah.
Very good. So typically there are two things we should remember about sickling crisis. One is hypoxia, second is dehydration, and third is infection. So that is infection lead to acidosis, and acidosis is a common precipitating factor of the sickling crisis. That's the reason whenever a sickle cell anemia patient used to get admitted in the ward, we always used to have a simple dictum. Stick a oxygen to him, run the IV fluids to see that he is hydrated well. Third, get a chest radiograph. Generally, either a UTI or a pneumonia is a common underlying cause of precipitating a sickle crisis, is what we need to remember. Very good. Now, the case number 2. A 6-month-old baby presents with severe anemia, failure to thrive, target cells, hypochromic microcytic cells, and hemoglobin F is persisting. Fetal hemoglobin.
In this patient now, persistence of HbF already diagnostic of a thalassemia. Thalassemia major is the diagnosis here. This patient will unfortunately have to stay on blood transfusion for the rest of his life, and his life will be complicated. But that's
right. Very good. So thalassemia is the persistence of fetal hemoglobin in this case of anemia, which is microcytic hypochromic, is a clue to thalassemia. Very good. Now, a 40-year-old woman presents with fatigue, dyspnea, paresthesia, red tongue, and the increased mean corpuscular volume with hypersegmented polymorphs and a low hemoglobin. So, what's your diagnosis?
Anemia with an increased MCV, you have to think of megaloblastic anemias. Megaloblastic anemia, 3 common causes, that is deficiency of folate, deficiency of B12, and pernicious anemia. Uh, Considering this is a woman and only 40 years old, diagnosis of pernicious anemia needs to be looked into. Um, Other than that, it can still always be a normal B12 deficiency, especially in vegetarian people, and that's about it.
Very good. So, what are the three important causes for non-megaloblastic macrocytic anemia, doctor?
Non-megaloblastic.
Non-megalo, because macrocytosis is always not synonymous with megaloblastosis. So, liver disease, alcoholism is another important thing, and hypothyroidism. These are the situations where we get a non-megaloblastic but macrocytic anemia should always be contemplated, is what we need to remember. And the importance of hypersegmented neutrophil, we should always remember. Even one single hypersegmented neutrophil is there. That is diagnostic of megaloblastic anemia. Even one single hypersegmented neutrophil. It is such a characteristic feature of the megaloblastic anemia. Another common thing we need to remember is always look at the knuckles. A hyperpigmentation on the knuckles in an anemic patient should always make you to think of the possibility of the megaloblastic anemia is what you need to remember. Very good. Now, a 60-year-old man post-gastrectomy presents with macrocytic anemia. He drinks alcohol regularly.
Now, first of all, this patient post-gastrectomy, we all know that the stomach is used for B12 absorption because it secretes something called intrinsic factor. This patient definitely has a deficiency of intrinsic factor, megaloblastic anemia. However, this kind of anemia is not going to get cured just by giving oral B12. You have to supplement parenterally because he can't absorb oral B12.
Absolutely. So, post-gastrectomy intrinsic factor deficiency, absolutely. A 22-year-old man with rapid anemia after being treated for malaria presenting with hinge bodies. So, what is your diagnosis, doctor?
Heinz bodies along with the anemia for treatment of malaria. So in malaria, especially in Vivax malaria, we have to give something known as a primaquine. Primaquine is a definitive cure for malaria. However, primaquine causes hemolysis in G6PD deficient people. This patient has G6PD deficiency. Again, the patient is a male, which goes more in favor of being a G6PD deficiency. Ideally, everywhere and especially in the hospital where I work, G6PD levels are always checked before we start the patient on any of these drugs. So there is a long list of drugs that is associated with the hemolysis in G6PD deficient people, and it is always wise to know at least the commoner ones of them.
Good. So, the most important thing Dr. Dhairya is telling all of us is the drugs leading to hemolysis in G6PD deficiency. Today only, you need to go back in your 200 pages notebook. You need to make that list, which is available in every damn book. But this is the one which is most often tested in the tomorrow's NEET PG exam. Another thing is, go to the Google images, look for the hinge bodies. So a lot of times, hinge bodies are being given as a image-based MCQ in the NEET PG exam. Now, doctor, a 44-year-old woman presents with a stiff, sausage-shaped fingers. Metacarpophalangeal joint swelling is there, and it is worse in the morning. So, what is your diagnosis?
So metacarpophalangeal joint involvement, which with I assume what is distal interpharyngeal joint sparing, rheumatoid arthritis.
Right. So, typically it is a early morning stiffening is one of the important feature to remember. Now, 23-year-old woman presents with diplopia, ptosis, and is unable to count 50 without her voice tiring. So if she counts 50, her voice is getting tired. She is having diplopia, ptosis. She also has muscle fatigue. So what's the diagnosis?
Myasthenia gravis.
Absolutely. And a 20-year-old woman with a lot of signs. She has arthralgia, depression, alopecia, oral ulceration, facial rash, normochromic, normocytic anemia, and also proteinuria.
But
So, what is your diagnosis?
so now, this patient, a woman of young age, I would have definitely sent an ANA and a dsDNA. This is definitely lupus. You have to look into what is the SLIC criteria, that is Systemic Lupus International Cooperation Council, SLICC criteria, which are now used in diagnosis of syphilis. So there are 11 criteria. Presence of any 4 out of those 11 is diagnostic. In this patient, we have arthralgia, we have depression, we have oral and oral ulcerations, we have facial rash. Already 4 of the criteria are fitted. Along with that, we have proteinuria, which is suggestive of lupus nephritis, and we have an anemia, which is also fitting into one of the hematological criteria. Overall, this patient at least fits 6 criteria. Just looking at this small history, this is definitely diagnostic of lupus. uh, I recommend everybody go back and read through SLICC SLIC criteria for lupus.
Very good. In fact, Vikram Thakur and many more who are all online, I'm so happy to see you all. So, in every week, at least a couple of days, we shall have these clinical sessions. The other day, we have Dr. Varun Soni, who is a topper in NEET PG and he's a MS General Surgery, excellent teacher, like our Dr. Dhairya. So, very passionate to help the next batch of the students who are preparing for the NEET PG. Always the best learning happens when we happen to sit with our age group classmates and we discuss between us and we get inspired and then go back rather than some old guy like us delivering a lecture and listening is always a boring thing. So that is the reason I'm so happy that all of you have joined the session. So please remember, every day evening, please be tuned to this YouTube channel and also tell all your friends that there's a lots of yarn that comes from the NEET PG toppers and wonderful, passionate teachers who come and teach over here. Now, 40-year-old man presents with septal perforation, proteinuria, and hypertension. So, what's your diagnosis, doctor?
Now, this patient, when you think about something known as vaginous granulomatosis, which is now called granulomatosis with polyangiitis, you'll have features of renal involvement along with an upper respiratory as well as a lower respiratory involvement. This patient has features of renal involvement as well as upper respiratory involvement, and septal perforation is very characteristic of granulomatosis with polyangiitis. This is diagnostic of, this is not diagnostic, this is pathognomonic of vaginous granulomatosis. We'll have to send an ANCA. Vaginous has C ANCA positive.
Absolutely. And one of the commonest differential diagnosis, doctor, we should never forget about veterinary is tuberculosis. A
TB.
lot of times, even TB also is capable of causing a cavitating lesion in the lung, leading to the development of hematuria, and also an upper respiratory involvement. And TB can lead to development of a renal tuberculosis presenting with hematuria. So a lot of times, in fact, one of the medical students' mother, I still remember, very wrongly diagnosed as TB. In spite of the evidences in contrary. You know, in India, we physicians, we say, first diagnosis is TB, second diagnosis is TB, third diagnosis is also TB. That's how the old time examiners only say. Of course, today we are saying that first diagnosis Corona, second diagnosis COVID, third diagnosis COVID-19. So, so TB is a great mimicker of a lot of other clinical vasculitic syndromes. Now, 50-year-old.
Which I would like to add that in the previous patient that we saw, SLE, SLE also is a great mimicker, and oftentimes you are always confused whether this patient has SLE or TB, especially in rural areas where people send Mantu. Mantu is absolutely pointless in India. I don't know why people send it, but just people see a Mantu positive and start AKT and they get no improvement. Patient is actually having lupus, or patient is actually having something else, but is being wrongly treated for TB. So that's something you often see in India, and I recommend all of my students, please do not fall into this trap. Do not believe tests like Mantu and Vidal. They are they are of no value in India.
Sure. Now, a 50-year-old man presents with vitamin B12 deficiency, peripheral neuritis. So, what is the most likely possibility?
Uh, this is just pernicious anemia. That is, the patient has antibodies against the parietal cells. This causes reduced secretion of your intrinsic factor. Intrinsic factor is secreted in the stomach, which binds to your B12 in the jejunum and is absorbed through the ileum. So, a deficiency of intrinsic factor, therefore, will cause a deficiency of vitamin B12 presenting as a megaloblastic feature. Again, as we discussed earlier, you have to give parental B12 in this case, or you can also give intrinsic factor.
Absolutely. Absolutely, doctor. Now, a 45-year-old woman presents with heliotrope rash and symmetrical proximal muscle weakness.
Dermatomyositis.
Absolutely. A 40-year-old woman with diplopia on lateral gaze, presence of nystagmus, paresthesia, muscle weakness. And there are oligoclonal bands in the lumbar puncture, and there is an increase in immunoglobulin G in the CSF. So, what is your diagnosis?
This patient has come with neurological features, but when you look at the patient's presentation, there is nystagmus, that is, there is ocular involvement, there is paresthesias, there is muscle weakness, very wide symptomatology in this patient, all of which is neurological only. Along with that, oligoclonal bands, it is very diagnostic of multiple sclerosis, especially in a young woman. Close mimicker would be neuromyelitis optica, also known as Devick's disease. However, this patient is not coming with features of your spinal involvement. Again, in NMO, you'll have aquaporin 4 antibodies, which is another pathognomonic feature to remember. So yeah, that's about it.
Very good. And one of the very important investigations that we ordered with this kind of a ocular presentation of multiple sclerosis is visual evoked potentials. Visual evoked potential. There is a delay of the visual evoked potentials due to demyelination, and sometimes, though the patient is clinically not very much like a textbook picture of MS, when you order for the visual evoked potentials, a delay of that sometimes brings out the diagnosis of the multiple sclerosis. Now, a 30-year-old man presents a week after an upper respiratory infection with paresthesia, and that rapidly becomes flaccid, acute flaccid paralysis. There is a very high protein, but no WBC, albuminocytologic dissociation. What is your diagnosis, doctor?
So now this patient has come with acute flaccid paralysis. When you examine this patient, he does not have any reflexes. He also has upper respiratory tract infection history, most probably caused by some organism like Mycoplasma pneumoniae. I have seen patients of this who have come after COVID. This is just GPS. What we see here is albuminocytologic dissociation, which means that the CSF protein is high, but CSF cells are not high, which is also pathognomonic of GBS. Treatment is with IVIG or plasmapheresis.
Absolutely.
Remember, no steroids in GBS. There will always be an option that this is an inflammatory case. They'll give you the diagnosis as acute inflammatory demyelinating polyneuropathy with stress on the word inflammatory. They'll hope that you mark steroids. Do not mark steroids here.
Absolutely. Now, 25-year-old man with flaccid paralysis of the legs, areflexia, mild upper respiratory infection, but then develops meningitis, and the CSF shows a rise protein and also increased lymphocytes in the protein in the CSF. So, what's your diagnosis, doctor, with the AFP?
So this patient, I assume he has a acute transverse myelitis. Uh, I don't see
Yes.
poliomyelitis.
So basically, a lot of times poliomyelitis typically presents with flaccid paralysis, areflexia, because it is the Anderson cell which get affected, and because it is a viral illness, typically you have a picture similar to that of a viral meningitis is what we need to basically remember. Now, a 35-year-old man presents solely with the palsy of the left side of his face, including his forehead, including the forehead, no sparing of forehead. So, is it LMN or UMN type of facial palsy?
This is an
Uh,
this is an
yeah,
element type of palsy. Now the difference is that in human palsy, because the facial nucleus is centralized, the forehead and the ocular muscles and the periocular muscles have bilateral innervation, whereas the lower facial muscles have unilateral innervation. So when the patient has an element kind of palsy, the whole half of the face is gone, whereas when the patient has a UMN kind of palsy, the forehead is spared. So this is very classical of facial paralysis. Another thing to note is that when you have a patient who has bilateral facial palsy, and we are not sure whether it is an upper motor or a lower motor neuron kind of palsy, we should remember that a patient who has an upper motor kind of palsy will still respond to emotional facial movements, but will not have voluntary facial movements. So he'll laugh when you tell him a joke, but he won't be able to smile if you ask him to smile.
right, absolutely. Now, a 35-year-old pet shop owner with a high fever, excruciating headache, a dry hacking cough, X-ray showing patchy consolidation. So, what
So
is the importance of this pet shop?
So these patients probably are exposed to a lot of birds. These features are very typical of chlamydia setaceae infection, also known as psittacosis. Treatment is very simple, just using doxycycline, but diagnosis is very difficult because chlamydia do not grow on cultures.
Absolutely. So the doxycycline, what are all the conditions like rickettsial infections, etc., where doxycycline is used? There is a list in your 200 pages notebook. You need to make a note of that. Now, a 40-year-old man who works in a abattoir, matlab mutton shop, presents with a sudden onset of fever, myalgia, headache, dry cough, and chest pain, and X-ray showing a patchy consolidation of the right lower lobe, and that is giving a ground glass appearance. So, what is a important diagnosis that you want to make in this given case?
Yeah. So in the current times, I would say this is definitely COVID-19 and nothing else. There is nothing else to think about it. This has to be COVID. But in this condition, just given the history of being in an abattoir, this is a Coxiella burnetii infection, also known as query fever. It is a zoonosis. It is caused by a spirochete. Treatment is using your penicillins, and that's about it.
Good. A 44-year-old guy who is a traveling insurance salesman with high fever, myalgia, abdominal pain, and hemoptysis, diffuse patchy lobar shadows. There is he is progressing from a non-productive cough to mucopurulent sputum, and the fever is persisting for almost 2 weeks. So, what is your diagnosis, and how do you want to manage?
So now this patient, he's probably been traveling a lot. He has been exposed to a lot of air conditioners, central ACs, everything. Very characteristic of Legionnaire's disease, also known as Legionella pneumophila. So that's another thing I would like to point out, is that this patient also fits into the typical COVID kind of presentation. Uh, in these times, always keep COVID as your diagnosis and think about everything else second.
Correct. Now, a 30-year-old man who is HIV positive has productive cough and hemoptysis, and the X-ray showing a round ball in the right upper lobe, along with a crescent of dome of air. So, what is your diagnosis?
A round ball inside your lung. It's definitely diagnostic of an aspergillus, a fungal ball, aspergillus infection. Another sad thing to point out is that in current times, because steroids are being indiscriminately used, aspergillus infections along with mucor infections have become very common in COVID patients, and mortality is very high. uh, Please avoid giving unnecessary steroids.
Good. 70-year-old woman presents with confusion, productive cough, and a lobar consolidation of the right lower lobe. So, what is your diagnosis, doctor?
So this is an older woman, and she has come with confusion and cough. We would have to think of cases such as just general sepsis along with. Mm, I'm actually not sure what this is. I'm sorry.
Yeah.
Uh,
So
this is just a
basically, a
pneumonia.
lobar pneumonia is always Streptococcus pneumonia. So pneumonias are divided into the bronchopneumonias, which are diffuse, interstitial pneumonias, which are caused by organisms like mycoplasma, viral, and you have the lobar pneumonias, which are much more contained, which are caused by the organisms like Streptococcus pneumonia, is what we need to remember. Now, a 50-year-old alcoholic, very good to see Purnasri Nallamadi and many more who are all online. Keep punching your answers also, doctor. So start thinking in terms of the clinical vignette. Tomorrow, NEET PG today has become a more clinical USMLE style clinical vignette based exam, right? Now, a 50-year-old alcoholic presents with sweating, tachycardia, and convulsions. So, how do you want to investigate the
Uh,
seizures? Uh,
So now this patient who has come with sweating, tachycardia, and convulsions, and is an alcoholic. Two things come to mind. One is hypoglycemia, and the other is delirium tremens. If this patient has recently had alcohol, then he is in hypoglycemia. If the patient has not had alcohol, then he is in delirium tremens. Have to evaluate for both. If you have to give diazepam for seizures, you have to manage the patient volume status, and you always have to correct vitamin deficiencies in alcoholic patients when they are admitted.
Right. So a lot of times what happens is whenever a patient is paraded into the emergency medicine department with seizures, so everyone will be running seizure, seizure, sister, midazolam, 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 etc. But I always practice even the principle that you give midazolam, no doubt, but commonly it is a hypoglycemia, which is a very important reason we should always think responsible for the development of seizures. Another important thing, whenever in a ward, an admitted patient happen to go into seizures, the two important reasons for development of seizures in the hospital in a admitted patient is one is hypoglycemia, maybe the insulin dose is overgenerously administered without monitoring the glucose properly by the nurse in the ward, or the second thing is dyslipidemia, hyponatremic seizures. These are the two things that should come to the mind. Now, a 40-year-old diabetic was started on tetracycline for severe access ulcerations, now presents with epilepsy and vomiting. So, what is
So
a possible diagnosis and
tetracy-
yeah,
tetracycline can cause acute kidney injury. Tetracycline leads to uremia. Uremia leads to all of these features. So that's it.
absolutely. So, typically, tetracycline can be accumulating in a patient with renal dysfunction, which is not uncommon in a patient who had been on diabetes. Now, 10-year-old boy presents with a fits for the first time. And his parents report that he stops talking in the middle of the sentence and then continues after 10 seconds later. So, what is the investigation you want to order and based on the history diagnosis?
Now, there are two possible diagnoses for these things. First is absence seizures, and second is that the child is just daydreaming as children do. You have to go for an EEG to find out whether or not this patient has absence seizures. Drug of choice is valproate. Another possible drug is levetiracetam.
Absolutely. So petit mal epilepsy should always be there in the cards, which is the absent features. The typical example is the kid will be looking through the teacher instead of looking at the teacher. The teacher will say, "Oh my God, the kid is looking through me, penetrating," instead of looking at me. So that is the classical story of the absent cheaters. If you go to YouTube, you type absent cheaters or petit mal. There are lot of cases of petit mal videos which are available of the patients. In fact, epilepsy, neurological signs, almost all the neurological signs, you have them available in the YouTube, so that in the modern time, learning is very interesting. It is no more boring reading through the books. You can see a lot of things on the YouTube, of course. Now, 15-year-old female presents with fits and fever. She has a petechial rash. It does not blanch on pressure. So, what is your
This is
possible diagnosis? How do you want to
uh,
evaluate?
this is a Neisseria meningitis infection. Patient has come with a rash. Along with that, patient has epilepsy and patient has seizures and the patient has fever. This is very diagnostic of meningitis. Next step to do would be to get a lumbar puncture. As soon as lumbar puncture is done, send it for culture, send it for cytology, and immediately start antibiotics. There
Absolutely.
should be no delay in starting antibiotics here.
And 30-year-old woman presents with seizures, arthralgia, and she's also having a thinning of her hair along with oral ulceration. So, what is the possibility and how we want to evaluate this given case?
Again, now you go back to the same SLICC, that is Systemic Lupus International Cooperation Council criteria, and you see that this patient, again a woman, again fits four of the criteria right here, which is already almost diagnostic of lupus. You have to send this patient's ANA, anti-dsDNA. You'll find ANA positivity, which is more sensitive, anti-dsDNA, which is more specific, and that's just diagnostic of lupus.
Absolutely. So now, a 50-year-old man presents with a severe stabbing pain and a wide-based guide. Very important clue. He has a ptosis, small irregular pupils, which are accommodating but not no light reflex. He has an absent deep tendon reflex and the position sense. So, what is your possible diagnosis and how do you want to evaluate this case?
So this patient who was having an Argyll-Robertson pupil, which is a pupil that accommodates but does not react to light, which is very much characteristic of tertiary syphilis, and that's what this patient has. Treatment is with penicillin. However, this patient's neurological features may not recover completely.
Absolutely. So, tabes dorsalis typically involves the dorsal column, and that is the reason the patient has got a wide basal guide. Any person whose dorsal columns are not working. So, whenever we are walking, why are we able to walk normally? How the mind knows that, brain knows that we are walking? There are two important sensory stimuli that inform the brain that we are walking correctly. One is the touch of our feet, second is our eyes, which are giving the visual clue. So the people who have a dorsal column problem still are getting the visual clues that are telling the brain that the reason the guide is normal otherwise. But when that guy just walks from the dining table and goes to the sink to wash his face, while washing face, what a person has to do, he has to close the eyes. So he closes the eyes and washes with water, and that leads to development of imbalance and ataxia. So this is typically called wash basin phenomena, which is typically seen in the patients who are having the dorsal column demyelination, whether it is subacute combined degeneration of spinal cord or Friedreich's ataxia or Tavis dorsalis, etc. Now, the next question. 60-year-old man presents with urinary incontinence, contralateral paralysis of the foot, leg, and shoulder. He is in an awake state, but silent, immobile, and a coma visual state. So, what is your diagnosis, doctor?
This patient is having a stroke because of the urinary incontinence, along with only paresis and not complete tense paralysis, along with having aphasia. So this patient has a cerebral infarct, probably an anterior cerebral artery infarct.
Yes. So one important thing we need to remember is it is the frontal lobe which is supplied by the anterior cerebral artery, and frontal lobe has the highest center of voluntary control of our continence. So there is a control of our continence which happen at the level of the sphincter, that is the spinal cord level, from the parasympathetic and sympathetic. Sympathetic coming from the lower lumbar and sacral segments giving the parasympathetic, and that is involuntary control. But the external urethral sphincter is under the control of the voluntary control, which typically comes from the frontal lobe, which is the uppermost center, which is supplied by the anterocerebral artery. And another important thing about anterocerebral artery is anterocerebral artery supplies the contralateral lower limb. Contralateral lower limb. There's a reason contralateral lower limb monoparesis is the one which is typically the presenting feature of ACS stroke. So that is the reason whenever a person has an ACS stroke, elderly man, what he will be doing, his hand is working, the other hand is also working. His one leg is working, but the other leg, while he is walking, he will be dragging the other leg. So he will be walking with a limp. And all the children, what they will think, oh my God, my daddy has some fracture. And they take him to the orthopedic surgeon. Orthopedic surgeon will do an X-ray, but there is no fracture seen. But why this man is having only a limp of one limb? Then comes a brilliant medicine resident like Dr. Dhairya, who will be examining the patient and will be doing the Babinski. Then he will find that limb, that single limb, that monoparetic limb, lower limb, is having Babinski positive. Then Babinski positive cannot be because of a fracture, unless there is an upper motor neuron involvement. So always we should think, any contralateral monoparesis in an elderly person, you should always contemplate the possibility, especially if the Babinski positive on that monoparetic limb, the possibility of the ACS stroke is what you need to basically remember. Now, 70-year-old man, contralateral hemisensory loss, paresis of the conjugate gaze to the opposite side. So, what is your diagnosis, doctor?
Now, this patient who has come with a hemisensory loss, which means there is a dense hemisensory loss. Along with that, there is also a gaze paralysis. So, this is diagnostic of a MCA territory infarct. I unfortunately don't remember which syndrome this is called, but
it is the most common presentation MCS stroke. See, there are two things we need to remember when it comes to the MCS stroke, and there is something called the crossed hemiplegia. The other entity is called crossed hemiplegia. So, what is the meaning of crossed hemiplegia? See, whenever if you look at the brainstem, in the brainstem, in the medulla, and in the midbrain, you have third and fourth granular nuclei. In the pons, you are having fifth, sixth, and seventh, and eighth, ninth, 10th, everything is there located in the medulla. So now your corticospinal tract is descending down, let us say on this side. So suppose if there is any infarction of the, let us say the cerebral level infarction, then you get facial palsy, and also the hemiplegia. Both will be on the opposite side. Because the facial palsy and hemiplegia, both of them will be onto the same side, opposite side. Whereas, if there is any infarction at the pontine level, in the brainstem level, then the facial palsy will be on one side, and ultimately the uncrossed fibers will go to the opposite side, right? So the hemiplegia will be on the opposite side. So this is called crossed hemiplegia whenever the infarction occurs at the level of the brainstem. Otherwise, if the infarction is at the level of the cerebral cortex, then both the hemiplegia, facial palsy, both will be on the same side. That's what we need to remember. Then another important point. Typically, whenever there is any bleed happening into the brain versus any bleed happening in the brainstem. So what is the difference between the two? Both of them lead to development of the eyes going into conjugate deviated state. But how do you differentiate? It is the ipsilateral conjugate deviation. For example, right side bleed is there, the eye will be looking towards the right side. Ipsilateral conjugate deviation if the bleed is there on the cerebral upper floor. Whereas at the brainstem level, whenever there is any bleed, then there is a conjugate gaze away from the side of the bleed. That's the point we need to basically appreciate. Now, doctor. A 70-year-old man presents with dysarthria in retractable hiccups. He has a nystagmus and also an ataxic gait. So, what is your diagnosis?
So now this patient who is not able to coordinate his movements, that is called dysarthria. He has a nystagmus, he has an ataxia. This has to be a cerebral infarct. A cerebral infarct in this patient, probably a posterior kind of stroke, vertebrobasilar infarct.
Absolutely. So, all of you know that the two vertebral arteries combine to form basilar artery, and the two basilar arteries will divide into posterior cerebral arteries, and typically we call it as the vertebro-basilar circulation. So, posterior cerebral artery is very important because if you look at the brainstem, the midbrain, pons, and medulla, you imagine that it is like a pillar, and behind the pillar there is what you call a plant creeper. So just like a plant creeper, your basilar artery will be creeping behind the brainstem. So any vertebro-basilar insufficiency obviously will lead to ischemia to the brainstem structures. So that is the reason typically patients will develop ataxic gait and nystagmus and dysarthria, because all these cellular nuclei associated with this is all located in the brainstem, and ataxic gait occur because the cerebellum has got connections to the brainstem. So all that gets interrupted whenever there is any basilar insufficiency is what we need to remember. Now, a 40-year-old alcoholic man, numbness and tingling sensation in the feet, loss of vibration position, loss of DTR, and macrocytic anemia. So, what is your diagnosis, doc?
Again, this same patient we have seen earlier as well today. So this patient coming with a macrocytic anemia along with the loss of deep tendon reflexes indicative of a neuropathy. Along with that, he also has paresthesias. This is very much diagnostic of subacute combined degeneration of cord due to vitamin B12 deficiency.
Absolutely. Vitamin B12 deficiency. Now, this is a easy 5 questions to pass through vitamin deficiency. 9-year-old boy, bite on spots.
Vitamin A.
Very good. 40-year-old female, celiac disease, epistaxis, PT elevated.
Vitamin K.
And 30-year-old man, fissuring of the angles of the mouth, seborrheic dermatitis.
I'm not sure, sorry.
The 30-year-old man, fissuring of the angles, riboflavin deficiency. And the 40-year-old man, flushing after coffee, Cazel's rash, angular psoriasis,
Niacin deficiency.
pellagra. And 30-year-old woman, bleeding gums, don't want to eat any vegetables.
Vitamin C deficiency.
Absolutely. So these are the common things to be remembered. Now, a 22-year-old woman presents with right upper quadrant abdominal pain and ascites. She has a hepatomegaly. The CT scan is showing increased uptake into caudate lobe only caudate lobe. Her regular medications are OCPs and Prozac. So, what is your diagnosis, doctor?
So this patient who is on OC pills, there is a risk of thrombosis. Along with that, the patient has findings in the caudate lobe only and has come with abdominal pain. Along with that, she also has liver features. This is most likely Budd-Chiari syndrome, thrombosis of the portal vein.
The thrombosis of the hepatic vein.
There's a hepatic.
Yeah. See, this is liver, doctor, and you have the stomach, and then you have the small intestine. Now, from the gut, the blood is passing through the mesenteric vein, and typically it will be forming the portal vein. And the portal vein will take the blood to the liver. And in the liver hepatic sinusoids, all the blood is being filtered, and from the liver, the hepatic vein comes out and it drains into inferior vena cava. Inferior vena cava takes the blood into the right side of the heart, all of you know very well, into the right atrium. अभी क्या हो गया? हेपेटिक वेन के अंदर थ्रोम्बोसिस हो गया. जब थ्रोम्बोसिस हो गया, क्या हो गया? ट्रैफिक जाम हो गया. The blood is unable to leave the liver and enter into IVC. But if you look at the Covenant's classification of the liver has so many segments. So all the segments drain into the hepatic vein, but there is only one exception. The caudate lobe is the only lobe of the liver which directly drains into the IVC without draining the hepatic vein into the IVC. It directly drains into IVC. So whenever hepatic vein gets the thrombosis, then all the remaining lobes of the liver will go to the caudate. They tell the caudate, hey, you know how to drain into IVC, no? Our hepatic vein is blocked, so please drain our blood into the IVC. So because caudate is receiving all the blood coming from remaining all the lobes through collaterals, the caudate hypertrophy is the hallmark. Only caudate hypertrophy is the hallmark of the Budd-Chiari syndrome. Then point number 2, if you happen to do hepatic angiography, that is venography, hepatic venography, you can also go to the Google images, and there you can be able to see classical pictures. You type spider web appearance of the Budd-Chiari. That is what you type into the Google images, you will get it. So what happens is, when only the caudate lobe is undergoing hypertrophy and all other lobes are draining into the caudate lobe, typically they form a spider web-like appearance if you happen to do the hepatic venography. So that is another classical venographic finding of the Budd-Chiari syndrome is what you need to basically remember. So Budd-Chiari presents with caudate lobe hypertrophy, abdominal pain, ascites because of the hepatic vein occlusion in a prothrombotic condition like oral conceptive pills is what you need to remember. Now, very good. 50-year-old women presents with hepatomegaly, darkened skin pigmentation, she is drinking heavily, she is having glycosuria. So what is your diagnosis, doctor?
So now this patient who is having a darkened skin, that is, she is having discoloration of the skin. On top of that, she is presenting with diabetes. This looks like bronze diabetes, which is characteristic of hemochromatosis.
Right. So this is a case of bronze diabetes or hemochromatosis. Absolutely. 40-year-old man with jaundice started on chlorpromazine, has intractable hiccups 3 weeks ago. So what is your diagnosis, doctor?
So chlorpromazine itself is known to cause jaundice, so that's probably just a side effect of chlorpromazine.
Drug-induced jaundice, very good. 50-year-old man, tender hepatomegaly with fever. There is an elevated mean corpuscular volume, elevated gamma glutamyl transpeptidase. So what is your diagnosis, doc?
GGT is a very specific marker for obstructive jaundice. So this patient might have some gallbladder. Sorry.
Yes. So
GGT.
Macrocytosis is an important clue here, along with gamma glutamyl transpeptidase. So gamma glutamyl transpeptidase is a very specific marker, especially for alcoholic hepatitis, is what you need to basically remember. Now, 40-year-old women, tender hepatomegaly on oral contraceptive pills. There is also weight loss, very important too, along with raised alpha fetoprotein. So what is your diagnosis, doctor?
Now, this patient who has come with hepatomegaly along with very important weight loss, along with an increased alpha fetoprotein. Now, without the alpha fetoprotein, you would have thought of multiple other diagnoses that could be possible in a 40-year-old. You could have thought of benign liver diseases. You could have thought a lot of shit, a lot of stuff. But when this patient comes with such a specific feature, then you have to think of carcinoma.
Absolutely, absolutely. So now, a 67-year-old man has a blood glucose of 650. Sodium is 163, which is very high. No past history of diabetes. He had been on IV fluids for a week, and other medications are cefuroxime, metronidazole, and dexamethasone. So, given these findings, how do you want to manage this individual?
Now, this patient who has come with a very, very high blood sugar level, along with that, he is having a high sodium level. So, this patient is having hyperosmolarity along with hyperglycemia. This patient is in HHS. What you have to do is to start the patient on zero point 0.5 unit per kg per hour of insulin. You have to monitor the insulin levels. You have to bring the sugars down gradually. You have to hydrate the patient, and then you have to uh, essentially stabilize the patient's sugar control and uh, plan for further treatment for diabetes.
Absolutely. So this is a hyperglycemic, hyperosmolar, non-ketotic coma state, and that need to be aggressively managed because it has a high mortality. Now, 60-year-old, his glucose is 550 and pH is 7.2. Sorry, pH is
So
7.2.
now this patient who has come with a pH of 7.2 and a glucose of 550, we don't need much more than this. This patient is most likely a diabetic ketoacidosis. Again, treatment of diabetic ketoacidosis is similar to what we discussed just now for HHS. However, HHS has a very much higher mortality compared to DKA, and the reason being that DKA is very easy to identify in patients. HHS patients are more often stable and are incidentally discovered. Secondly, again, on further examination, I see that this patient's potassium is 3.0. We cannot start insulin in this patient just yet because insulin is going to cause a further drop of potassium. We have to start correcting the potassium first, and then we start insulin. So that's our answer here.
Absolutely. A lot of times, the patients who come in DKA, what happens is insulin normal function is it moves the potassium from the extracellular into intracellular space. So, people who are having diabetic ketoacidosis will have a lot of vomitings. Because of the vomitings, they are all dehydrated. And because of the dehydration, they will be having increased renin, angiotensin, aldosterone. And aldosterone is known to lead to development of caliuresis. And that is the reason their total body potassium levels is low. But all that potassium, instead of being inside the cell, because insulin is required to move the potassium from serum into the cell. So even though the total body potassium is low, in these people, all that potassium is outside the cell, that is in the plasma. That is from where we are drawing the sample and looking for the level. So that is the reason when a patient of DKA walks in, his potassium may be looking normal, but once you start insulin therapy to the patient, you should always get the potassium checked, and often the potassium levels will fall drastically after you started the insulin therapy. Is very, very important to remember. Now, 40-year-old diabetic actor is started on propranolol because he has got a stage fright. He collapses after a day shooting. He has not changed his insulin regime. His glucose is 40. So, what is the cause for collapse and how do you manage?
So this patient who has come with a recent onset of beta blocker induction, what happens is that beta blockers mask the symptoms of hypoglycemia. So if at all the patient was going into hypoglycemia, patient who is not on beta blockers will have sweating, will have tachycardia, will have palpitations. However, this patient who was on beta blockers does not get these symptoms and directly comes with a collapse, directly comes with a seizure. That's what happened to this gentleman. We just have to give him glucose and he'll be all better.
Absolutely. So that's called hypoglycemic unawareness is very common in type 1 diabetes especially, very common. Now, a 50-year-old diabetic presents in coma. He is febrile, diminished breath sound. He has a warm extremity. His blood glucose is 375 and WBC count is increased and neutrophilia is there. So what is your diagnosis, doctor?
This patient is most likely having a diabetic ketoacidosis along with an acute infection. Because there are breath sound diminished, this patient probably has a respiratory illness, lower respiratory tract infection, which just precipitated a diabetic coma. First step is to send culture, start antibiotics, start IV hydration, and manage the sugars.
Always remember two precipitating factors that lead to the precipitation of decay. One is infection and other is infarction. So typically patients who have stroke, patients who are having MI, a lot of times when they come, all our focus is on their stroke or on anemia. But actually we should also look into their sugar levels because quite often patients presenting with stroke and MI have a concomitant decay because the decay is precipitated by the underlying infarction or infection. That's what we need to remember. Now, a 50-year-old woman with tachycardia, sweating, agitation, her husband is diabetic, and she has a history of Munchausen syndrome. So, how do you want to approach?
This patient who is having tachycardia and sweating, and her husband is diabetic. Her husband is probably on some or the other OHA. This patient has just taken those OHAs, or this patient has just taken that insulin, and she has come with these features because she just wants to act on her Munchausen syndrome. That's the so. Munchausen syndrome is always very dangerous to diagnose, very difficult to diagnose, and if you end up diagnosing a patient with Munchausen syndrome, the first thought they have will be that you are calling me insane. So there are a lot of medical legal issues with it.
So, Munchausen syndrome, where she is trying to create a factitious hypoglycemia by injecting her husband's insulin drug, which has been given, not because her body produced a lot of insulin. So, how do we differentiate a hypoglycemia which is due to the factitious hypoglycemia versus the real hypoglycemia because of the hyperinsulinemia? So,
So
if
we
it is
can
produced
send
inside the body, every time it is producing
C-peptide.
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 Correct.
So
So high
C-peptide.
C-peptide is insulinoma like conditions where endogenous insulin is there. Whereas normal C-peptide with the hypoglycemia with hyperinsulinemia means it is the exogenous insulin which is being administered. Now, doctor, a 50-year-old man has blunt trauma to the chest, marked dyspnea. A nasogastric tube is placed to decompress his stomach. But on chest X-ray, the nasogastric tube is seen on the left side of the chest. So, what is your diagnosis, doctor?
This is just a rice tube that has gone into the bronchus rather than going into the esophagus. It's just very simple. You have to remove it and you have to reinsert it. That's
Yeah. So, a good number of times, whenever there is any diaphragmatic rupture, then on the chest X-ray, there will be a bowel or a nasogastric tube in the chest. So that is what we need to keep in mind. Now, a 55-year-old man is involved in road traffic accident, comes with chest pain. A friction rub is elicited. Multiple premature ventricular ectopic beats are being found. So, what is your diagnosis? Especially with friction rub, multiple premature ventricular beats in the backdrop of the trauma.
Friction rub is usually a pericardial pericarditis in this patient who has a history of trauma, it is more likely to be just an injury to the pericardium.
Right. So we should always think the possibility of any myocardial contusion, which is not unlikely. Now, if we take the left atrium, left ventricle, right atrium, right ventricle, closer to the sternum, these are vertebral bodies. So closer to the sternum and more anterior is always the right-sided chambers. And in the myocardial contusion in trauma, because of the steering wheel injury to the sternum, you should always think of the right-sided chambers to get basically contused. Now, a 30-year-old man is stabbed in the back and he is in respiratory distress. His BP is 90 by 50 and there is a pulse rate which is 110. He has a dull breath sounds in the left chest. And what is your diagnosis?
So now this patient has come with muffled heart sounds. Along with that, there is a tachycardia. Along with that, there is a low BP. This patient has a tension pneumothorax. We have to do a needle thoracostomy immediately to release the pneumothorax, and after that we can go for further management.
Right. Now, a 40-year-old man is stabbed in the chest, shortness of breath, and the wound is heard to suck with each breath. That wound which is being noted. So, what is the most likely diagnosis in this given case?
So this patient who is having a sucking sound from the wound when auscultated, this is the open pneumothorax that has been caused due to the injury.
Absolutely. So, 30-year-old man is stabbed in the left side of the chest and he is short of breath, restless, chest is clear to auscultation. There's a rise of the venous pressure with the inspiration, which is a very important clue. Kusumal sign. The chest X-ray showing globular heart. So, what is your diagnosis, doctor?
Tamponade.
Very good. So, the classical side of the Kusumal is the cardiac tamponade is Kusumal sign. So, normally, if you take the heart, the jugular vein is draining, and whenever we take inspiration, then the inspiration will create a negative intrathoracic pressure, which sucks the blood from the jugular vein, and the jugular vein is expected to collapse when it is inspiration. But whenever there is a cardiac tamponade, there's a lot of blood around the heart, which is preventing the right atrial blood from flowing into right ventricle. So that is the reason the right atrial pressure is very high. So even there is a negative intrathoracic pressure, that is not significant enough to suck, because jugular vein cannot drain into a chamber which has a very high pressure. So that's the reason the jugular vein at the time of inspiration, it is expected to collapse, but it is not collapsing, but rather standing very prominent, which is classically seen in the case of the cardiac tamponade. Constrictive pericarditis also is what you need to basically remember. Now, doctor, 50-year-old man, he remained intubated for 10 days. He is now pyrexial. He has a diminished breath sound. And there are gram-negative rods, swabs from the ventilator. So what is the organism that comes to your mind in this case of the ventilator-associated pneumonia?
So this is just a Pseudomonas aeruginosa, especially common in COVID ICUs. Unfortunately, a lot of patients get Pseudomonas aeruginosa infections in COVID. It is a very commonly drug-resistant bug and very difficult to treat sometimes. Another thing is that it won't respond to your normal antibiotics a lot of the time. It doesn't respond to cephalosporins except for cefepime, or you have to give ceftazidime and avibactam. So that's about it for Pseudomonas aeruginosa.
Absolutely. 30-year-old woman, severe right lower quadrant pain, watery diarrhea, she is pyrexial, and she visited her parents in the countryside a week ago. So what is your diagnosis, doctor?
So now
Severe right lower quadrant pain.
Watery diarrhea has very few characteristic diagnosis. One would be your cholera, another would be your Yersinia. So this is just Yersiniosis.
So Yersinia is a very close mimicker of acute appendicitis is what we need to remember. Now, a 20-year-old man, right knee pain, swelling, not associated with any trauma, synovial fluid is aspirated, reveals many diplococci, and there is a creamy yellow penile discharge. What else is required? So, what is your diagnosis?
Gonorrhea.
Correct. So we used to have one professor in All-India Institute of Medical Sciences. Very vocal, very good teacher. So he used to always say a dictum. अगर एक जवान आदमी यूनिलेटरल नी जॉइंट स्वेलिंग के साथ आ गया तो आप पूछना मत भूलना. आप ये पूछिएगा आप उनको कि भाई आप कुछ रेड लाइट एरिया को गया क्या बोल के definitely you should ask is what our professor used to always say, because the only condition that lead to monoarthritis of the knee joint in a young man without trauma is gonococcal arthritis is what you need to remember. They are all classical clinical aphorisms. Any time of your clinical practice, they stand true. Now, 50-year-old diabetic man, painful, swollen right leg, X-ray showing air in the soft tissue.
So this this patient who is having infection of the soft tissues. Along with that, he is having production of gas. This is a clostridial infection in a diabetic patient. This patient might require emergency surgery, might require amputation to prevent further spread of the infection, and requires aggressive antibiotics.
Absolutely. 40-year-old man, profuse watery diarrhea, 2 weeks of antibiotic therapy, sigmoidoscopy shows yellow necrotic areas, classical. So what is
This
your
patient,
diagnosis, doctor?
very easy to diagnose that this patient has a Clostridium difficile infection that is caused due to inappropriate use of antibiotics. What happens is that patients, especially post-surgical patients, are given a lot of antibiotics. They destroy the normal commensal flora of the gut, and they let this Clostridium difficile grow. Treatment for this is IV metronidazole and oral vancomycin. Uh,
Very good.
Nowadays, even daptomycin is used for Clostridium difficile.
Very good. Now, the last 5 cases in our OPD, doctor, before we call it a wonderful review discussion of the USMLE clinical vignette pattern, new NEET PG style questions. A 4-year-old child, these are all poisonings. A 4-year-old child presents with anorexia, nausea, vomiting, blue line on the gums, foot drop, anemia. What is your diagnosis, doc?
Lead poisoning.
Absolutely. 16-year-old girl, weakness, excessive salivation, abdominal pain, raindrop, pigmentation on the skin, and what is your diagnosis?
I don't know, sorry.
This is the very famous poison that was detected in one of the Pakistani president's assassination case. It is the arsenic poisoning. Arsenic is a tasteless, colorless poison, which is often used silently to kill the people. Raindrop-like pigmentation is the classical feature of the arsenic poisoning. Now, a farmer, acute shortness of breath, skin is red in color, and he smells bitter almond.
Cyanide poisoning.
Cyanide poisoning, which is part of the rodenticides and fertilizers, is what you need to remember. 40-year-old woman with headache, memory impairment after installation of a gas fireplace. Her skin color is pink. So, what is your diagnosis?
carbon monoxide poisoning. I would like to add about carbon monoxide poisoning that your normal SpO2 probes that we use are not going to show any difference in carbon monoxide poisoning, because carbon monoxide is also just almost as dead as the oxygenated hemoglobin is. Another thing is that the carbon monoxide will also have a high or normal PaO2. That's why it is difficult to diagnose carbon monoxide on routine respiratory tests unless there is a high level of clinical suspicion.
Great. Now, 50-year-old agricultural farmer, lot of times this question has been asked in the previous NEET PG exams. Nausea, vomiting, hypersalivation, and bronchospasm.
OP poisoning or carbamate poisoning, we can't say which one of the two. The patient is coming with nausea, vomiting, sometimes has seizures, has hypersecretions. Remember the mnemonic dumbbells, that is the diarrhea, urination, uh, bronchospasm, bronchorrhea, MSS, lacrimation, salivation. This is very characteristic of OP poisoning. Treatment is using your atropine and your pralidoxin.
Absolutely. And one very, very, very common mistake done by a lot of residents in their first year is, whenever you have a OP poisoning patient, what is the main part of the treatment? You are trying to give atropine. So we immediately start atropine. But one thing we need to remember is, what is the action of atropine on the urethral sphincter? Typically, atropine is anticholinergic. So normally what does cholinergic will do? Cholinergic contracts the bladder, contracts the detrusor, and relaxes the internal urethral sphincter. Whereas atropine, what will it do? Atropine will relax the bladder and constricts the internal urethral sphincter. So that is the reason, before giving atropine only, you need to be sure to pass the Foley catheter. If you don't pass Foley and you have dosed the patient with atropine, later if you have to pass the Foley, means it will be very tight. You have to penetrate very tough constricted internal urethral sphincter, which need to be remembered. So that is wonderful, doctor. It is a great pleasure once more to study along with the NEET PG topper, and a lot of learning, and thanks to all the online students, Akhilesh and everyone, Purneshri for joining. And every week we will have one session with Dr. Dhairya whenever he is out of the duty, post-duty state, so that we all enjoy learning and revising a lot of general medicine. Thank you, Dhairya.
Thank you for having me.